I'm just waiting to let a few more people in.
Okay.
Lorraine, maybe like 30 more seconds.
Okay. Okay. I'd like to call the August 25th, 2025 PDASC meeting to order at 2:03 p.m. Christina, can you please call the roll?
Yes. Pallavi Aurora. Pallavi Aurora. Okay. Renee Bovell. Renee Bovell. Sean Brown.
I am here. Thank you.
Thank you. Angela Bryant.
Here.
Thank you. Allison Siborowski. Allison Siborowski. Lorraine Diana.
Present.
Thank you. John Elliott. John Elliott. Robert Embry.
Here.
Thank you. John Gambrell.
Here.
Thank you. Candace Hall. Candace Hall. Sharita Golden.
Here.
Thank you. Jim Gutman.
Here.
Thank you. Darren Johnson.
I am here, Christina.
Thank you. Kathleen Lochran.
Good afternoon.
Thank you. Erica Miller. Erica Miller.
Good afternoon, I'm here.
Oh, thank you. Eric Morse. Eric Morse. Mark Nicole. Sean O'Brien.
Present.
Thank you. Mandy Poplowski. Mandy Poplowski. Amy Prentice.
Here.
Thank you. Kimberly Robinson. Kimberly Robinson. Glenn Schneider.
I'm here, thank you.
Thank you. Kelly Schultz.
I'm here, Christina. Thanks.
Thank you. Danita Tolson.
Here, present.
Thank you. Thank you. Sean Tunis.
I'm here. Thanks.
Oh, thank you. Joseph Wynn.
Hey, Christina, I'm here.
Oh, great. Thanks. And then I think I saw Pallavi Aurora join us. Pallavi, are you here?
Yeah, I'm here.
Okay, great. Thank you. We have quorum.
Thank you, Christina. We'll move on to the approval of minutes from the June meeting. First, we need to approve the last meeting minutes. Do I have a motion to approve the minutes as drafted?
So
Just Dr. Tosin, second.
Thank you. All approved, say aye.
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 All opposed, say nay. The minutes are approved as drafted. Thank you. So Christina, have we received any public comments?
Yes, Lorraine, we have received public comments. We received 4 written comments. which were shared with the PDASC and posted on the website. We received one comment after the deadline of the comment due date, which will be shared with the PDASC and posted on the website after today's meeting. We have 2 requests for oral public comment today. To our public commenters, you will have 1 minute and 30 seconds to speak. Please state your name, the organization, agency, employer, or other entity with which you are affiliated, if any, or whether you are a consumer, and the agenda item that you would like to address. And then you can start your comment. I'm going to first call on George Huntley. Mr. Huntley, I do see you on the line. If you would like to tell us the organization that you're with and the agenda item you're speaking to, and then I can get the timer started.
Yeah, thank you. I'm with the Diabetes Patient Advocacy Coalition. I'm the CEO, and we're here to speak on the Jardiance and Farxiga consideration.
Okay, you may begin.
Thanks. On behalf of DPAC and the millions of Americans with diabetes, including over 600,000 Marylanders, thank you very much for the opportunity to speak. This stakeholder council plays a vital role in advising the PDAB on drug cost solutions and that also protect patient access, and that's really critical. Jardiance and Farxiga are not optional medications. They are essential therapies for people managing type 2 diabetes, especially those at risk for heart failure or kidney disease. Restricting access would undo years of progress, increase complications, and raise hospitalization costs. While affordability is really important, we encourage the council to advise the board against relying on upper payment limits. UPLs may unintentionally disrupt manufacturer contracts with PBMs, leading to higher copays, restrictive prior authorizations, or even worse, formulary exclusions, all of which will ultimately harm patients. Instead, we ask you to recommend patient-focused non-UPL solutions, first requiring insurers and PBMs to pass negotiated savings in the form of rebates, discounts, or other concessions directly to patients at the pharmacy counter. This alone would cut the out-of-pocket costs nearly in half. Second, delink PBM compensation from drug prices to remove incentives for inflated prices and ensure patients benefit from long-term savings. I urge the board to prioritize these strategies that reduce the cost at point of care while protecting uninterrupted access. Thank you for your time.
Thank you. We appreciate your comments. Up next, we have Tiffany Westrich Robertson. If you could please let us know what organization, agency, employer, in what you are affiliated with, and then the agenda item that you would like to speak to, and then I can start the timer.
Sure, thank you. I am affiliated with a few groups or a couple groups, including speaking as a patient with an autoimmune disease who takes a biologic for treatment. I'm also with AI arthritis, which is in the International Foundation Autoimmune Autoinflammatory Arthritis. I am also the lead of the Ensuring Access Through Collaborative Health, or EACH, and corresponding Patient Inclusion Council, or PIC Coalition, working on drug affordability policies that benefit patients. Okay, you may begin. Thank you. All right. Thank you so much for this opportunity today to talk with the Stakeholder Council. I know that you have had an enormous amount of work that has been done and your work in advising the board. And I wanted to just recognize that work, and it is appreciated. And I think just to start off by saying, really, we are all in this together to better patients. And I want to keep that at the forefront of everything that we're doing. In saying that, we do urge the Maryland PDAB and the PDASC to evaluate all potential policy tools, not simply move forward with an upper payment limit as a default solution, particularly when patients largely report that affordability challenges are rooted in evolving personal life situations, collective costs for medications, and insurance barriers. We did report this in a new publication that is just out that I would love to share with you if you haven't already seen it. But I want to use the rest of my time just to make note that there's a reoccurring issue that continues to arrive involving casting doubt on the authenticity of patient organizations and people like me who are leading organizations and receive percentage of funding from pharmaceutical companies. There is no place in a professional environment to intentionally cast doubt on any person or group with the rationale based on where funding comes from. This behavior challenges our integrity and our ethics unfairly. One more sentence, please. We will no longer tolerate this, and we ask all stakeholders, no matter your belief, to please welcome us, appreciate us for the value as we do you, instead of trying to undermine other credibility and gain it for yourself. Let's use our energy in a positive way to help patients access the treatment they need. Thank you.
Thank you. Thank you for coming. Thank you. That concludes the public comment for today.
Thank you all, and thank you, Christina. Andrew York is now going to give us a presentation and update on the cost review study process. Andrew?
Thank you, Chair Diana. I'm hoping to keep this very quick. So we have, so this is just going to give the Stakeholder Council some general background and context to prepare you for today's meeting. So this is going to just kind of go through where we are in the process and talk about what we're trying to accomplish today. So if we go to the next slide. So you can go to the next slide. So as you may know, we're conducting the cost review study process for 6 drugs. In the, I guess, July meeting, Christine, if you go to the next slide, the board made a preliminary determination on an affordability challenge for Farxiga and Jardiance. And there are still 4 drugs that are still undergoing the cost review study process and have not had their preliminary determinations occur at this point. So today, we're only looking at the preliminary determinations for Farxiga and Jardiance. Next slide. In that meeting, so in the July 28th meeting, the board had the opportunity to examine Farxiga and Jardiance, and they ultimately had to decide whether the use of the prescription drug product has led or will lead to affordability challenges for the state healthcare system or high out-of-pocket costs for patients. And then also whether or not the use of that has led to the affordability challenges or high out-of-pocket costs is consistent with the labeling of the FDA, approved by the FDA or standard medical practice. And then they also had to identify the circumstances under which the prescription drug product has led or will lead to an affordability challenge for the state healthcare system or high out-of-pocket costs for patients. So that's what occurred in the July 28th meeting. Next slide. Again, the outcome of that meeting was a preliminary determination. This is non-final and subject to revision or modification. Next slide. And the immediate step after the preliminary determination is the process for the board to draft a report, or sorry, the board and board staff to draft a report. So this is one thing that is kind of a parallel process to what we're doing now. This report summarizes the information that the board considered in conducting the cost review study process. It includes the board's deliberations. It articulates the circumstances or indicia reflecting the affordability challenge, and then the board's preliminary determination. So this draft will be made available before it becomes final, and the public will have a chance to provide comment on that draft or on that report. Next slide. And that, the preliminary determinations were articulated through board resolution. So I'll go through those right now. Next slide, Christina. So the circumstances that the board identified. So they made 2 preliminary determinations that the use of Farxiga and Jardiance have each created an affordability challenge to the state healthcare system. And each of those circumstances were as follows. So the first one is the percentage change in WAC over time is substantially larger than the percentage change in inflation, i.e. the rate or increase of the inflation. This was found for both drugs. The next circumstance was that at the 90th percentile, patient out-of-pocket costs in certain markets is disproportionate to the net cost of the drug paid by payers. This was identified for both drugs. And then the third circumstance, so for Farxiga, the total gross spending for Farxiga for state and local governments exceeded 1% of the gross prescription drug spend for state and local governments. And then for Jardiance, they found that the total gross spending for Jardiance and for the state and local government, the spending for Jardiance for state and local government exceeds 1.8 of the gross prescription drug spend for state and local governments. We're going to go through each of these in depth in the next section, but these are the circumstances that you're you're trying to identify. So I just wanted to provide an overview of those at this point, but we'll go into that in the next segment of this meeting. Next slide. So the next step is to go into the policy review process. Next slide, Christina. And as part of that, so the first step is the board makes a preliminary determination on an affordability challenge. If they have determined or made the preliminary determination that it does cause an affordability challenge, we then try to identify the drivers and recommended policy options. That's kind of where we are in the process now. We'll go into this a little bit more in the next part of the meeting, but what we're trying to do through this discussion is identify the drivers. So the circumstances identify the what. Here's what we've identified in the data that indicates that there may be an affordability determination. And now what we're trying to do is understand the why. What market conditions have caused this affordability challenge that the board has identified. And then for each of the drivers, we have to identify policies that can hopefully address that driver. One of those policies could be upper payment limit options, which has its own process. But then also we're trying to look at non-UPL policy options as well. They have a slightly less standardized process just because our statute doesn't specifically articulate anything around non-UPL policy options. But it is something that we want the stakeholder council and board to deliberate on and consider. Next slide. So this is a graphic that you guys have seen before, but the step where we are now is in the information gathering step. So the first step for any of these policies is to gather information for additional policies. So I'll just briefly go through these. If the staff and board are interested in moving forward with a UPL, then there's an entire process that we have to go through. So we gather information, staff recommends that UPL is an appropriate policy to address one of the circumstances, and they recommend methods. The board then has a meeting and provides feedback. Based on the board feedback, the staff then publishes the actual calculations and methodologies that actually kind of shows the math and the assumptions that go into that work. And that becomes available for public comment. The board may host technical meetings to work through some of the technical issues that can be identified as part of the methodologies. And then anytime the staff makes any updates to the methodology or calculations, then it would be published for public comment. And then once there's a final version, the board can adopt the UPL as a proposed regulation. For the non-UPL policies, again, we're at the information gathering phase now. The staff gathers information for additional policies. Staff identifies the drivers and the policies that address those drivers. In a board meeting, we can get board feedback on those policies. Staff can update their recommendations and then publish draft resolutions. And then the final step is for the board to adopt those resolutions. And then the third bar at the bottom just shows that that first slide that I went over, that we have to finalize the cost review study report as well. So that's a kind of a parallel process. So we'll be publishing a draft of that report for public comment, and then the board can adopt it as their final determination and final cost review study report. Next slide. So again, that just gives you some general background on where we are in this process. You can go to the next slide. So in terms of the next steps in the role for the PDASC, so in today's meeting, you can go to the next slide. The board, the purpose of the policy review process is to confirm the drivers and market conditions causing an affordability challenge, and then or challenge phenomena, and then also identify policies that may address those drivers and redress the affordability challenges. So that's the purpose of the policy review process. Next slide. One of the first steps is the information gathering phase. So we can gather information through informational hearings, stakeholder council input, which we are going through today, expert testimony hearings, board staff research analysis, and then also requests from eligible government requests for information from eligible governmental entities. Next slide. So today we're going to be going through the information gathering process through stakeholder council input. So the board may request input from the stakeholder council, and this input can be a request for general input and ideas on policies or more specific requests for specific information. You'll see the actual request in the next segment of this meeting. And then board staff may provide the board with summaries of the input from the stakeholder council. So our intention is to take all the input that the stakeholder council has today and make it available to the board for their consideration. Next slide. So that's an overview of the process. Chair Diana, if you want, I can go straight into the next presentation, which will just kind of flesh out exactly what we're discussing today. Oops, you're on mute.
Yep. Andrew, that would be great if you want to just move forward.
Okay.
Can I ask a question, please?
Yeah, sorry.
So this is Darren. I wanted to let you get through that presentation, Andy, but I do have a couple questions to ask you related to items in there. So going back to the drug selected cost review study process, do you have any update on the other 4 products? What timeline that we can potentially or expect with those, either from a staff viewpoint or the board or anything else?
Yeah, I think this was going to be in the announcements at the end of the meeting, but we have published the dossiers for 2 of the additional drugs, Ozempic and Trulicity. So we're in a 15-day comment period at this point, and we'll give you those deadlines at the end of the meeting today. So then once we receive public comment, we would then publish a subsequent version of those dossiers, and the board can take action on those at any point. I don't think the agenda has been published for any upcoming meetings. So I don't think there's a set schedule on any of these, but we are kind of in the dossier draft comment process for Ozempic and Trulicity, and then I don't think there's any timeline on Dupixent or Skyrizi.
Okay, thank you. The next question I had, you had mentioned under the high out-of-pocket cost for patients and the 90 percentile, certain markets. Can you elaborate a little bit more on what markets you saw or what markets were in? If it was in the dossier, I apologize. I don't remember if you were specific on the markets for that item.
Yes, the resolutions that were passed were articulated the specific markets, and we can go back to the discussion from the board. I know it's definitely for the commercial market. I think they were specifically referencing the state and local government market, so they made their determination based on that market, but it also applied to the commercial markets, which I believe is why they phrased it this way.
The state and local, was it broken down by county at all?
I don't think so. The data it's just an indicator. So you can actually go into the it's in the dashboard posted online. So it's an indicator just of if it's state and local government. So it's not broken down by county. I think further analysis may be possible, but it's not something that was available to the board.
Okay, thank you.
Okay.
I see Sean Tunis has his hand up as well, Andy.
Yep, Dr. Tunis.
Yeah. Thanks for reviewing the process. So, I was just reflecting on the first public comment. I think it was George Huntley, and kind of raised this idea that perhaps upper payment limits might unintentionally have the ultimate effect of raising cost to consumers through different PBM contracts or maybe formulary changes or whatever. And I don't know that upper payment limits have ever been implemented before, so I have no way of judging whether that's a plausible, unexpected, unintended consequence. So I'm just wondering, I assume somewhere in the process that you outlined, there'll be some exploration of the possibility of those kind of unintended consequences, which I think, as far as I know, there's certainly with upper payment limits, there's no empirical evidence that any of those things would occur, but I think it's reasonable to worry that they might. So just wonder what your thoughts are on that.
That's a great transition to the next slide deck, but I would just agree that for all of these policies, we should be looking at the strengths and weaknesses of policies and any potential unintended consequences, and then try to identify ways to avoid any potential unintended consequences. So this is something we would certainly think through if we were implementing that.
Great. And just one other comment, because again, I thought both public comments were really helpful. And I do think the point of the second commenter that we shouldn't be rejecting public input from patient advocacy groups simply because they receive industry funding. I think we're obligated to kind of be aware of that, but take into account the substance of the, of the input, and not kind of take the position, well, if a patient advocacy group gets any industry funding, they're obviously in industry's pocket, and we should just ignore anything they have to say, which I think isn't really the right way to go about things.
So,
Thank you.
one other thing to note, just I should have mentioned this, and we will announce this at the end of the meeting, but just as I was going through the other information gathering, one of the tools that we have is something called informational hearings, which is kind of a pretty broad forum for different folks to provide stakeholder feedback. We do announce as part of that the kind of the things that the board is asking for additional information on. But this is a chance for anyone from the public, both stakeholders and also patients and other different groups to provide feedback to the board for their consideration. We have 2 informational hearings that are scheduled, both on the same day. One is going to be September 3rd, and we'll go over this again at 1 p.m. and then also September 3rd at 6 p.m. So we do encourage folks to participate in that process as well. Christina will go over those. The team will go over those announcements at the end of this meeting in case you missed that. But I just want to flag we will be going through that process as well, and that's another chance for folks to provide input.
I'm new to this board, but I'd like to, I don't know, this may have been covered before. I'm John Gamble. I'm a retired physician ophthalmologist. But have we looked at the cost increases in the several different layers of increasing costs for these pharmaceuticals? Talking about the wholesale cost at the production level, the increased costs at the PBM level, and the subsequent increased costs with insurers and retailers. Some of that cost might be justified at the research and development level, but the PBMs and the retail pharmaceuticals may be marking up to a much higher degree simply for profit motives. And do we have any idea of how much that total cost is related to PBM and retail markups as well as insurer markups? Because I'm also an elderly citizen and I have to buy pharmaceuticals as well.
It's a great question, Dr. Gamble, and something that I think we'll talk about in this next slide deck a little bit. But in the dossier, we were able to track different pricing metrics over time. So one of them is the acquisition cost, which is NADAC. The one that was specifically referenced is something called the wholesale acquisition cost, which is we compare to the MSRP of like a car, for example. There is the average wholesale cost, which is a derivative of the wholesale acquisition cost. So we do track those over time. But to your question of like linking to things like ingredient costs or research and development, that's something that's very difficult to do. And part of what we're hoping to gather.
I'm not talking about research and development costs. I'm talking about you can't do that at the wholesale pharmaceutical level, maybe not.
Right.
But then these medications are sold from the wholesale pharmaceutical level, and they pass through the PBMs and the insurers to the retail pharmacist.
Yes.
Each level has a profit motive, and each level, I'm sure, insists on a profit motive. And I'd like to know what percentage of the total cost to the patient arrives at each of those levels.
It's a great question. And we can try to pull some of that. So again, we do find it at the acquisition level, which is kind of sale price from the wholesaler to the pharmacy. And then also the like final sale price that the insurer pays on, which is usually based on wholesale acquisition costs. And we do see paid amounts. What is tricky is, and we've had this conversation a few times, so welcome to the Stakeholder Council. But one of the things that's a little tricky is that there are kind of like off-invoice discounts and rebates that affect the net cost of the drug that is generally not publicly available. So what we're seeing is kind of gross spend throughout the process, and that's pretty well documented throughout the dossier. But there are some unanswered questions that we're actually hoping to get answers to as part of this information gathering process. So some stakeholders may have information in responses to those questions that you have that may be out of reach of staff at this point.
Okay.
Great. Yeah, so but these are both from Dr. Tunis and Dr. Gamble, great questions that I think lead into the discussion that we're hoping to have today. So if there are no other questions, we may move into the purpose of this meeting, which is the input from the Stakeholder Council.
So I'm going to give a little introduction while you get the slides loaded, Andrew.
Yep.
Andrew's going to give us an overview presentation of the board solicited Stakeholder Council input. This presentation aligns with the board request for Stakeholder Council input document that Christina provided us as meeting materials on August 18th, 2025. It is the hope that PDASC members are prepared to discuss those questions. We are going to use the presentation to organize the discussion. Some logistical items. I'm going to be asking for comments and recognizing speakers and helping to manage the conversation. I would like to ask Andy to provide the introduction for each part of the conversation and to help organize the topics for conversation. Please raise your hand if you would like to speak and I will recognize you. Please state whether your comment pertains to a specific drug, both drugs, or as a general comment. Andrew, you may begin.
Great. Thanks, Diana. So, Christine, you can go to the next slide. So as mentioned, the purpose of this call meeting is to gather stakeholder council input. So the board has requested input from the stakeholder council, which we'll go over shortly, and then board staff is going to provide the board with summaries of the input for their consideration. Next slide. So as remember, so we're going to keep this presentation. We're going to come back to this slide just so you can reference it. But ultimately, what we're asking for is related to the different circumstances that they've articulated. And the ask is actually on the next slide. So the input that the board is trying to capture from the stakeholder council is answering these three pretty broad questions, though these are ultimately the questions the board needs to consider when they're making their determinations on what policies to include. So first, what drivers caused or contributed to each of the circumstances listed above? Please explain how that driver operates in practice and how it contributed to that circumstance. So this can kind of be in a conversational format. We are going to go over what a driver is in just a moment. Next, what information from the dossier, or I guess anything that the stakeholder council references, demonstrates or supports the existence of this driver? So like, how do you, how can you demonstrate that this driver exists? And then finally, can you identify different policies that could address this driver and how they actually address the driver? For each policy, we're hoping to discuss the strengths and weaknesses of the policy, possible implementation of the policy through legislation, regulation, or enforcement, and then also the potential impacts of the policy. As you can see, these are all extremely broad topics, and I think allows for some robust discussion. You don't necessarily need to answer every element of these topics, but we will kind of allow for conversation on each one. So we'll kind of dig in. If folks don't have discussion or talking points on these, we'll kind of move on to the next one. So I think we do hope to explore for each circumstance, go through the drivers, for each of the drivers, go through these questions, though, we'll kind of see where the conversation goes. So for example, if you have policy options that you're working on, we'll kind of follow the conversation where it goes. All right, so next slide. So I'll just give you some additional background information and then we'll dive in. Next slide. So just a couple of terms. This is kind of a technical discussion, and we do appreciate the expertise that the stakeholder council brings to the table. So we spent a lot of time talking about what a driver is, and it basically at a high level means the factor that causes a particular phenomenon to happen or develop. And we're going to give an example of what a driver could be. But basically, again, this is the why of why the different circumstances exist. Is there some sort of market dynamic that's happening that is causing this affordability challenge to exist? We also do discuss a couple, we have specific questions on different policy options that we just wanted to provide some context for. One is a real-time benefit tool. And this is a tool that displays out-of-pocket costs estimates in the EHR at the point of prescribing. And then we also reference in some of these subsequent questions, deductible smoothing. And that's a Medicare Part D program that helps beneficiaries manage their out-of-pocket prescription costs. That basically allows the plan to allow beneficiaries to spread their costs evenly throughout the calendar year, rather than paying kind of like the upfront deductible and then having a nominal copay throughout the year. So these are two different things that are referenced in some of the policy questions that we have at the end. Next slide. So we did want to briefly go through a quick example of what a driver is and what it could look like. So for the circumstance of a disproportionate out-of-pocket cost to the net cost, the possible drivers could be a couple examples could be patients with high out-of-pocket costs are using drugs for which their health plan gets lower rebates than average, i.e. they're using a non-preferred drug. Another reason could be that patients with high out-of-pocket costs have high deductibles, or that coinsurance rates are based on paid amounts, resulting in patients paying a higher percentage of the net cost for the drugs with plans with high rebates. So this last one basically means, a lot of times co-insurances are based on it's a percentage of the drug cost. And if the drug cost is the paid amount versus the net amount, the patient can be paying a much higher percentage than what the coinsurance indicates that they're paying. So this is just a few examples of what the drivers are, or what the drivers could be. As you can see, this does get very technical. So I think we will kind of follow the conversation where it goes. But when you are thinking, this is the kind of details that we're looking for in terms of explaining why these different circumstances could exist. Next slide. Now, I think one thing just is to kind of prime the conversation, we had a series of questions that we were going to kind of allow for folks to respond to, primarily because the discussion around these conversations will probably feed into the broader conversation, the questions that are asked, right? So what are the drivers? What are the policy solutions? So we have a few questions here that I'm just going to kind of leave open. And then I think Chair Diana can just allow folks to respond to the questions as they see fit. And then once we feel like we've kind of finalized or work through all the talking points on these questions, that should kind of give the stakeholder council enough ideas to respond to the actual ask from the board, which we'll go back to at the end. So with that, I'll walk through each of these questions and then we'll come back to this tape page, and then we'll just kind of let folks respond as they see fit. So if we go to the next slide. So some of the questions that may help guide the discussion around the first circumstance is, how much do production costs increase over time, and what percentage of the WAC increases are attributable to production costs? Another question could be, what other costs would explain higher rates of increase in the WAC set by drug companies? Another question is, do the minimum rebate amounts negotiated between the drug companies and pharmacy benefit managers impact the WAC, and if so, how? And then finally, how does the WAC and potential increases in WAC impact PBM manufacturer negotiations? So again, these are a lot of things that may describe these market dynamics that aren't readily available to policymakers such as PDAB staff and the board. I'll also just go through the next questions, and then we'll just kind of open it up for some general discussion. Again, these are pretty technical questions, so we don't expect the stakeholder council to necessarily have answers on all of them. I think we'll just kind of see where this conversation goes before we go back to the broader conversation that I mentioned at the beginning. In terms of exploring some identified policy options, some of the questions could be, what are the barriers to adoption and utilization of real-time benefit tools? What are the barriers to adoption, enrollment, and utilization of deductible smoothing under Medicare Part D? What policies would ensure that patients with high deductibles and coinsurance are not paying a larger proportion of the net cost of the drug? How might WAC inflation penalties, which is charges for manufacturers that increase WAC faster than inflation, disincentivize WAC increases? What changes to BBM contracts would discourage WAC increases? How might UPL's upper payment limits change the incentives for WAC increases? How would the application of a UPL to the drug impact formulary placement of the drug? And then finally, what frameworks or contextual information should be considered for each drug if setting a UPL? So you can see there's a broad number of questions here that I think, as you work through some of these questions, can facilitate some of the conversations later. So with that, we can go back to the next slide, and I was going to turn it over to Chair Diana just to take questions as we see fit. Again, when this conversation is over, or when folks feel like we don't really have any juice to squeeze out of these questions, we can move back to the original, the actual ask from the board members, which is identify the drivers. How did you find those drivers, and then what are the policies to address those drivers? So with that, I think if anyone wants to weigh in on some of these technical initial questions, feel free to raise your hand.
So I see Jim Gutman has his hand up. Jim?
Yep, thank you. I just want to comment on one aspect of this. And as we look at these policy options, we should pay particular attention to how much time it will take to develop some of these alternative policies as opposed to UPLs. The need for relief is just right now. I think we all know that. And yes, we want to do the right and complete job, and we should, but that doesn't mean we should wait to do things until some of these other options can be considered. I note that the county executives testified in the General Assembly this year on the legislation that passed about how urgent the need is. That's the same kind of thing they said in December of 3 years ago. and certainly what we expect them to say in June in urging the activity. So just as we look at all these worthy options, and they are worthy, let's look in particular at what can be done now. I see this when I'm doing volunteer drug plan counseling for the SHIP, the State Health Insurance Assistance Program. The need is to do something now, and I hope we give that the emphasis it deserves. Thanks.
Thank you, Jim. Dr. Danita Tolson, your hand is up. Go ahead.
Yeah, I also want to second what the gentleman just said as far as moving forward with putting urgency that we need to put forth with moving forward with the prescription drug affordability. I think is very urgent that we need to continue to push forward with this. But I do have a question. Can we put in place any penalties, or I'm sure some penalties are already in place. I think I remember us discussing that before, for the inflation for the prescription to some of the drug companies. And can we continue to negotiate and write down some things that we want in place and send forth to add to some of the previous negotiations?
Oh,
And I can respond if that's
okay.
Chair Diana, do you want me to provide initial responses on any of these items?
Please respond to that.
Okay, sure. So I think so there is an inflation penalty in Medicare. It's not currently in place at the state level. So I think that's exactly the kind of conversation that we're hoping to have today of like if the stakeholder council would provide input and thinks that that's a useful policy tool. One of the questions we had here is like, have we seen an impact on this based on the policy that you've seen? But those kinds of policies are exactly what we're looking for as part of this process. They would fit kind of in that non-UPL policy, but that's certainly something that the stakeholder council can provide input on.
Thank you.
Yeah.
I'm going to call on Kelly Schultz next.
Okay.
Dr. Gambrill, I'll get to you next.
Okay.
Okay. Kelly,
Yeah.
you're muted, Kelly.
Sorry about that. Thank you, Chair Diana.
problem.
Perhaps you or Andrew could help me out with this, and maybe it's just a point of clarification. So a lot of these questions that are being asked here today, specifically, let's just say, take the third bullet point here about PBMs, and then, there's other questions about insurers and out-of-pocket expenses with the actual patient. A lot of those recommendations have come from industry in the form of public comment in the past. So are you looking for us today to kind of go over again the public comment about the very specific policies in which we had recommended, and to have those open discussions about the public comment from before? Because it seems like this is very similar to if there are other policy ways in order to go about lower cost to the patient. A lot of those conversations were being had. I just want to know where we are with that.
Yeah, so I would say everything that has been provided to the board as public comment is available to the board and staff and taken into consideration. I think the purpose of these meetings is to supplement where there may be gaps. So I think you're welcome to reiterate any recommendations that you made, but I think what we're looking for here is new information that can fill in some of the gaps related to that. So we do kind of have a list of the different policies that have been recommended, and you're welcome to reiterate those. But I think the big thing here is, so for example, you mentioned number 3. I'm not sure that this has been directly addressed in public comments. Does the minimum rebate negotiated amount between drug companies and the pharmacy benefit manager impact the WAC? So these are the kinds of things where we think that there's gaps. I think we understand the general policy recommendations, but there's some market dynamics that are not readily available to staff and policymakers that we're hoping different stakeholders throughout the supply chain can shed some light on. So that's the ultimate goal here, is to give information that's not currently available. And I would say that anything that was submitted in a public comment will get due consideration. And I think all the policies that have already been listed are certainly on the table.
Yeah.
Thanks, Andrew.
Dr. Gambrill, go ahead.
Other than UPLs, do we have any other leverage for pharmaceutical costs? Because UPLs are at the end of the cost sequence. And it may render some of these medications unavailable to patients if they're taken off the list, if only the state of Maryland does this. The costs have been driven down at the federal level for certain drugs because of the leverage of Medicare, and Medicaid. But at a state level, can we drive costs down with UPLs without losing access to these drugs? Because some of these drugs are very necessary for the optimal care of some of patients. Is there any experience with UPLs in other states or other situations to drive the cost down without the loss of access to the drugs?
I can respond. Yeah. So, Dr. Gambrell, thank you for the comment. So this is primarily a forum for us to get input. So I think flagging this as something that the board should consider is a great comment. I can try to answer your questions, but I don't think, I want to just be careful that this doesn't devolve in just me talking. I think we want to really hear the stakeholder council's feedback. But just to your questions, upper payment limits are a novel policy. Maryland would be among the first states to implement one if the board decides to move forward with that. The framework that we have pointed to of examples of this kind of living in the wild is the New York Medicaid program, and then also the Massachusetts Medicaid program have a comparable system, and they attribute some savings to that system. I can send you the slides that we provided on that. Again, that is specific to the Medicaid program, so that's one thing to differentiate. And then also we point to the Medicare negotiations from the Inflation Reduction Act as another kind of framework of how this could work, but we would be on the cutting edge of that. So I think all the different concerns that you're bringing up are things that we want to address. I think you had mentioned, go ahead.
So New York has done this with other drugs and it has been successful without losing access to the pharmaceuticals?
The way that both of those programs work is that their Medicaid programs identify drugs that are disproportionate drivers of cost to the Medicaid program. And then basically they then begin to negotiate for additional supplemental rebates to drive their costs down. And then if they're not able to come to an agreement, they have boards comparable to the makeup of our board that can then go about setting, they're called different terms, but it's a similar idea as what we're doing in Maryland. Again, it's specific to Medicaid. Go ahead.
So it's basically yes, even though it's with Medicaid primarily.
It's a similar flavor. So it gives us an idea of how this could work. Yeah.
Okay.
Thank you.
So nothing's a one-to-one comparison. What we're doing with upper payment limits would be a novel policy. Other states are working on it at the same time, but we would be on the front end of that.
Sean Brown, you're next.
Hi, everyone. I'm with Lupin Pharmaceuticals. A lot of these questions I deal with every day, could go on and on about all of them, but just to give some perspective from the generic industry, for example, production costs increasing over time. During the pandemic, our transportation costs multiplied 3- or 4-fold. But because we're locked into contracts with PBMs, and there's only 3 games in town, really, when you think about the consolidation of purchasers in the supply chain, we're not able to take price increases like a brand product would be able to. And so that's what leads us into the issue of shortages, where 56% of the drugs in shortage are $1 or less per unit. And it's an economic problem. No company is going to want to use their manufacturing capacity to make products that are $1 or less per unit. And it goes further. It's 75% of drugs in shortage are $5 or less per unit. So there's no real elasticity within the generic industry to cut the margin to make up for additional production costs, because generic manufacturers don't have leverage in negotiations with PBMs. Somebody during the public section of this meeting mentioned something, though, which is delinking the fees from the list price, delinking PBM fees from the list price, because right now there's an incentive for the PBM to take the drug with the highest list price so that their fees will be higher and that their rebates will be higher. Where if you delink that, it does reduce that incentive to push for the higher list price product. and hopefully opt for a generic product, which is usually a fraction of the cost. So I say, I mean, I think there are ways out of this, but we are pretty jammed right now as an industry, because, for instance, the IRA, the Inflation Reduction Act, which is designed to reduce the cost of brand products, creates an uncertainty for the generic industry where we don't know what price to anticipate 8 to 10 years down the road when we finally come to market. And that's caused generic companies to abandon pursuing a lot of products they normally would have brought into the market as competition. And the truth is, competition lowers the price of drugs far more effectively than price controls. So I'd say for the generic industry, we need help. We don't need more price controls, or, you know, when we go by a percentage of increase, you're talking about a drug that is a nickel. If it's 100% increase, it's a dime. If you're talking about a brand product, it might be $3,000 a month, and a 15% increase is $450. So I think there's got to be some distinction when we're looking at drugs between a generic drug or a biosimilar drug and a brand product, and that the industry is really highly leveraged and it's not benefiting patients anymore. And I endorse that policy that the speaker mentioned earlier about delinking PBM fees or even PBM rebates from the list price on products, because it creates these perverse incentives in the system, which is leading to all the problems that we're looking at from the other end of the telescope. Thank you.
Thank you. Glenn Schneider.
Thanks, Madam Chair. Hi, Andy. Hi, everybody. So I want to start with, I think the rubber hits the road with what the industry sets the price at. So when we talk about what are PBMs and their influence in all of this, it starts with where the price is set by the manufacturer. I think we can look at other countries that have done this sort of work to limit costs. And we know that folks in the US are paying a lot more for drugs than people in other countries like Canada and parts of Europe. So I think my whole point on all this is thinking about how upper payment limits seem to make sense. Everything that we have learned, every meeting that we have had where we've talked about the potential for success at reducing the cost and still preserving access, UPLs seem to be like the best option. And I appreciate the timing parts of all this. We need to get relief here soon. And I just wanted to start again thinking about the fact that the manufacturer sets the cost, everything else that follows from that. And if we can get there, and if other countries have gotten there, figuring out a way to limit the cost, we should be able to do the same, even though UPLs are a novel concept in our country.
Thank you. Darren Johnson. Darren. I think Darren is
He may be
frozen.
frozen. Yeah, if you want to just go to the next
Okay,
one. And go
Sean
back to-
Tunis, let's go to you and we'll come back to Darren.
Yeah, you know, just to say I'm, you know, fully aligned with Glenn, and you know, as as many people have said since the beginning of this process, you know, drugs don't do anything good for people if they can't afford them. So what I was, you know, I was just thinking as we were talking about wholesale acquisition costs and the many kind of complex considerations that, you know, we need to take into account as we're thinking about upper payment limits. And I hope this isn't getting ahead of things, but like specifically for Jardiance and Farxiga, you know, since that seems to be where the board has kind of focused their attention so far, I'm kind of assuming that in the context of the Medicare drug price negotiations, a lot of these factors about wholesale acquisition costs and the many other potential consequences of, you know, establishing an upper payment limit, at least for the Medicare program, when they negotiated a maximum fair price, were taken into account. So one of the things I'm wondering if, you know, Andy or anyone else has any comments on is like, I don't see how it would be possible for Maryland to kind of, if we kind of linked our upper payment limit to the maximum fair price negotiated by Medicare, why there would be different negative consequences on patient access, et cetera, that haven't already been considered at the national level?
Yeah, that's a great comment. I think we take it as a comment. I don't have any particular response to it, but it's a good comment.
Thank you.
I guess
Darren, you're
maybe,
back on.
sorry, the
Oh,
only part of that was a question, and I'm sorry if it wasn't really a question, was sort of if Andy or others know to what extent many of the considerations like wholesale acquisition costs and other factors were part of the Medicare negotiation process, including potential sort of negative impact on negative impacts that might otherwise actually increase patient out-of-pocket costs, which is obviously what we want to avoid. So maybe the question, Andy, is like, is there anything that we can learn from what was considered as, in the context of arriving at the Medicare maximum fair price that would give us some reassurance that we're not going to cause some damage at the state level to patient access through linking our price to those?
Yeah. Okay. I understood. Yeah. So the Medicare teams did publish kind of documents or explainers on how they went about the negotiations. And I think it's probably fair to say that they did consider things like list price and that they were, trying to target savings and then also trying to understand the impacts on patients and ensuring that there was no loss of access. I think the fact that it was a negotiation and an agreement that the CMS and the manufacturers came to together, I think addresses a lot of those concerns. And so that's something we can certainly learn from in our work. So.
Great. Thank you. Darren, you're back.
Thanks, Lorraine. Yeah, my computer froze. I'm on the phone now. So thank you very much. I apologize. I had a general comment or two, and then I had a couple specific questions related to the drivers, actually. But I think, as a couple of folks on the council here have indicated, I think the drivers you see in a lot of this, and it's something the industry has mentioned, I've talked about a lot, are either benefit design by insurers or, again, the market dynamics, the supply chain dynamics of the PBMs. Particularly if you look at the WAC issue, really you got PBMs, as we have talked about, demanding higher rebates. So that in turn sometimes does make companies have to adjust for the WAC in order to meet those higher rebate demands for formulary placement purposes. And that goes again to patient access. And again, it goes to the cost issue. And then you have, insurers with their benefit designs and how they change those benefit designs. And we've talked about, and this goes to Kelly's point earlier, whether we can have legislation in Annapolis to pass rebates through, to make changes to the benefit design that will help patients get access quicker and reduce their cost quicker. We've reiterated that a lot. So, I think, Andy, on the drivers, those are the drivers that I would see, at least on the first two bullets. But then I have a question, and it's a question I raised probably 2 years ago. And now it's really coming to fruition. In the first bullet, it's mentioned the percentage change in WAC over time. Can the staff tell me what was the time frame that was used for both drugs, Jardiance and Farxiga, in their cost review? Were you going back to 2014 when both products were initially approved by FDA? So you have an 11-year time frame, or was there a different time frame? And you might recall I raised this 2 or 3 years ago. If we go back so far, you really can't do that. So I wanted to get a sense as to what was the over time that was utilized for the two products.
The information you can actually see, I think the WAC versions are redacted, but you can see comparably for NADAC and I think the federal schedule. Just so they received that same graphic and same information for the WAC and the AWP. And what it shows is basically from launch. So the information that was available to the board was from launch, and then it shows every WAC increase over time from launch. I don't think they articulated a specific time frame for which they were looking. I think they were looking across the life of the drug, but I can check with my team and see if that was articulated in the resolution. But they did have information available from the launch of the drug. So
yeah, I saw I saw 5.5, the figure it talks about, but it didn't have dates. So okay. So you're telling me it goes back 11 years. So again, the question I raised, way long time ago, is that an appropriate time frame? Really, is what I'm getting at, and I don't think necessarily it is an appropriate time frame to be looking at. And then I had the next question I had again. We talk about affordability challenges and things like what is affordable, what is the challenge, undefined terms, which we've talked about in the past, as to what is unaffordable. And so without those being defined, a lot of this again is very problematic for the industry going forward. But I'll stop there. I have other questions as we continue to go. I want other people to talk, but I do have some other questions, and I do have some other things I'll comment on.
Sure.
Great, thank you. Dr. Golden?
Thank you. So I guess I wanted to circle back to a comment Dr. Tunis made earlier about Medicare. And one of the things that struck me in reviewing the written comments that were submitted is that for many of the patients that were surveyed, it seemed that switching from, maybe their commercial or employer-based insurance to Medicare resulted in higher out-of-pocket costs and affordability challenges. So I do think that we actually need to look at that and look at those data. I know that there's a plan to survey more patients, but that was a concern that stood out to me in particular, particularly because people, at age 65 have to switch to Medicare. So a lot of things switched with affordability, particularly for specialty pharmacy medications. And the other thing that struck me in that comment that kind of follows up on what was just said about what does affordability mean? It seems like it does mean different things to different people. So, there's the cost of the drug, but often it's not so much the cost of the drug, but also the cost of all of the other out-of-pocket expenses that patients may have. So, durable medical equipment and other things that aren't covered. So I do think we're probably going to need to be more specific in which costs we're talking about. But I think at the end of the day for the patient, whatever the cost is, if it's an extra $10, and that's actually a good negotiated copay, but they're paying $300 for, some other cost, and that $10 is going to seem like it's an affordability challenge. So I think it's relative to what their income is, what insurance they have. That seemed to be very clear from the written comments that were submitted.
It's a great comment. I was just going to echo your point that came up in the public comments that came in, that it is important to get the patient perspective. And when they say why the drug is unaffordable, it gives a lot more context. I think it's a great point. Thank you. So we had this series of kind of technical questions, and it seems like we're kind of addressing some of the broader questions now. So I think we can just go back. So I think the way that we wanted to structure this conversation, and we'll see how it goes, folks may not have answers to any of these questions, but I think we wanted to just go circumstance by circumstance, ask about the drivers, and then any drivers that are suggested, kind of walk through these different questions. So what drivers contributed to the circumstance listed above, what information demonstrates the support or existence of this driver, and then identify policies that it could address this driver. I think, hearing some of Mr. Johnson's comments, I think those were some of the ones that were most directly responsive to some of these. So I'm not sure if we want to start with one of those as the example for this kind of discussion. So if we want to go back up one more slide, Christina. So let's start with this first circumstance that applies to both drugs. which would be, and again, this is the actual concrete ask from the board, is can you please respond to these questions? So we'll start with the first circumstances. What percentage of the change in WACC over time is what percentage change, excuse me, the circumstance is that the percentage of change in the WACC over time is substantially larger than the percentage of change in inflation and the rate of increase in inflation. And again, this applies to both drugs. So Christina, if you go to the next slide. So I guess, what are the drivers that cause the WACC to increase faster than inflation? And Mr. Johnson, I'm not sure if you wanted to dig in with some of your comments. I think you articulated two reasons that may be occurring. I think the big challenge for us, and we have seen that in some of the comment letters that come in, is just what information can we use to demonstrate or support the existence of that driver. Right? We've seen it in public comments, but it's hard to get the data to articulate that, so or like validate that. So that's one of the things that staff is kind of working through. So I'm not sure if we wanted to work through that, or we can also just open it up and see if other folks have drivers that we want to talk about related to WACC inflation.
Darren Johnson.
Yeah, Andy, I don't have specific data. Again, as you know, it's for any trust purposes and everything, the companies are going to house that information. But what I can say overall as a general policy of what we have seen is, in order to obtain formulary placement for products, companies have to deal with the supply chain dynamic of the PBMs driving that process. And so again, if you want specifics, you need to try to, and it's what I think Sean talked about, some of the other commentators earlier, you need to have policies, and they are non-UPL policies that have been raised in the legislature before, whether you're delinking rebates, whether you're passing through rebates, whether you are addressing those dynamics that are raising the numbers. And pharma has, I think that we have submitted information. Pharma has in the past of some surveys they've done, some other things that they've done. I think if you look at the Each Coalition survey that we saw and what was presented to us, 100%. This is in their data, and this is, again, I hope these advocacy groups are going to be given more time at the September technical meetings in order to go through some of this stuff so they can talk about their own information and we don't have to sort of interpret it. But when you look at their survey, 100% of the patients who stopped their medicines due to affordability cited insurance barriers, and 3/4 that skipped their dosage were due to insurance delays. So again, I think you really need to talk to the advocates, because they're the ones that can tell you specifically some of the items that can be changed in order to address the issues, address some of these drivers. I don't have the specifics. Maybe some of those companies can and may provide that to the staff, to the board, to show you those WACC differences. But I think it's pretty evident that there are issues outside of the manufacturer's control that is really problematic and dealing with these issues.
Very helpful. Yeah. I think one of the things that we're trying to get a handle on is, like, if we are looking at, like, what are we looking at to validate that? And I think you've cited a number of good studies. We see it in the literature, I guess, and we're trying to get that list together. But a lot of it is like descriptions that it makes sense for this dynamic to happen. But if we were trying to validate that, like, yes, this is happening and here's the contractual provision that causes this, that's kind of what we're trying to understand. So if any stakeholders are able to kind of provide that information, that would be useful. And echo your comments on the patient groups. I think that's a very useful source of information. So appreciate your comment there. All right. Are there any other ideas of why the WACC, the wholesale acquisition cost, may be increasing faster than inflation or the market dynamics, structural issues within the pharmaceutical supply chain that may be driving this. I think Mr. Snyder kind of mentioned some of this during his initial comments. And then I think Darren or Mr. Johnson may have also brought up a second driver kind of in the same vein. Okay. Hearing none, we're going to go on to the second circumstance that was identified. So at the 90th percentile, so if you have all patients lined up, at the 90th percentile, patient out-of-pocket costs in certain markets is disproportionate to the net cost paid by payers. So again, this describes the dynamic where if a patient's paid amount is, or percentage that they owe is based on the paid amount, and there's a lower net cost, then the patient can be paying a disproportionate share. So we're trying to understand the dynamics of that circumstance. So Christina, if you want to go to the next slide. And all this information is available in the different tables that are available as exhibits. But do we have any thoughts or discussion on what drivers can cause the patient's out-of-pocket costs to be a disproportionate share of the net cost? I think Mr. Johnson kind of alluded to some of this in some of his comments, but also welcome anyone to more directly describe what drivers in the pharmaceutical market may be causing this circumstance.
Yeah, Andy, again, I'll just reiterate real quick. I think again, you'll get that from the consumers. There was legislation passed this year, doesn't take effect for another year or so. But insurers use accumulator adjustment programs. They use other, again, types of benefit designs that shift the cost onto the patient. Sometimes they don't, that's not always known to the patient. But if you can, or I would say if the board can support legislation that would address some of these issues in the future, I think that would be very helpful for patients. I think that'd be helpful for the legislature going forward. So again, we've made these comments before. There are a lot of what we've talked about, changing maybe the first dollar coverage to help patients with some of the designs would also, be beneficial. So I think those are some of the specifics we've raised in the past that could address this. Because when you talk about the 90th percentile, you're really talking probably high deductible plans. And just by definition, they're going to have high costs. So the question that I had really was, why was the focus just on the 90 percentile? You need to look at the broader benefit design and the impact that co-pays, co-insurance, deductibles, and all of that have on patient cost.
Very helpful. Yeah, if I think if you can give, and this is a broader question to the group, like exactly what we should be looking for. And that last part that you'd mentioned is like we need to look at the impact of deductibles, co-insurance, co-pays. I think that's the kind of feedback that we're looking for, is like, how do we go about doing that? Like, what should we be looking at to answer the questions that you was just asked? Like, I think the dossier shows the analyses that we've done. But I think we're trying to fill in gaps that are left by the dossier. So again, more broad, and maybe something that can come up in the September 3rd information gathering meeting, but like, are there specific things we can be looking at that can validate and provide clarity on some of the questions that you've just articulated? That'd be helpful. Great. All right, Dr. Golden.
Yeah, I was going to comment. I mean, another contributor is that if a patient is on, say they're on multiple medications and they're on an assistance plan for one medication, then that doesn't count toward their deductible. So then that means for other medications, maybe where they're not on an assistance plan, now they're actually paying more out of pocket. So it seems like it gets to be a little bit of Russian roulette in the sense of, if they're on an assistance program, it's almost like they get penalized for being on the assistance program because they've got to pay, for other costs. So if there was a way to ensure that the assistance being provided could count toward their deductible plan, now that involves policies with multiple payers, but it seems like that's like one challenge that contributes to out-of-pocket costs for for patients. And the fact that with Medicare, they aren't eligible for some assistance programs. So those are like two important contributors.
Great comments. Thank you.
Yeah,
And just one quick note, we are getting some feedback in the comments section. Glenn Schneider just had some input regarding the price of prescription drugs. So I
Yeah,
just want to
and we can,
ensure
yeah,
that
yeah.
ensure
Thanks for
that
flagging
they're
that, Chris.
yes.
So that will be considered. Thank you, Mr. Schneider. You're welcome to provide additional context, the way you might not be available to speak, but received, and we will consider it. Thank you.
Rather,
Yep, go ahead, Dr. Gambrill, sorry.
Yeah. Rather than looking at co-pays and deductibles, which are important, I guarantee, I think a lot more of the cost lies in profit motives in the PBMs and the pharmaceutical companies themselves. Now, I don't know how much leverage the state has to push those back, but I think I would rather see the state trying to push back on or decoupling the PBM fees from the insurers contracts, such that they're less, because the PBM's motivation is profit, the pharmaceutical company's motivation is profit. If you may not be able to drive the profit motive down on the pharmaceutical company, but the PBM is an intermediary that's sheer profit. So I think I would, if it's at all possible for the state to elect some, and I wouldn't know how to do this because I'm not a politician, but some legal way to push back on the PBM fees and decouple them from profit motivation. Hello?
Yep, comment received. So I would say that PBM reform seems to be a pretty there's a lot of interest both at the state and federal level. So I think if there are specific recommendations from the board and if the stakeholder council has specific input, we would certainly welcome that. So I think we've heard that there's value in decoupling revenue, or I guess I don't want to call it profits, but like specific revenues to the cost of the drug. So I think we can think through that. So that's certainly a policy that can be recommended by the board as part of this process.
Sean?
Yeah, I mean, I guess this is a comment on drivers. I think in your list that you showed in the slide before this, one had to do with kind of like meeting a certain threshold of total spending, on pharmaceuticals or healthcare. I wasn't sure what but I mean, this is obvious, but one reason why we're spending a lot of money on Jardiance and Farxiga is they're really good drugs that help a lot of people. They're good for people with diabetes and heart disease and renal failure. So, a lot of them get used because, they're good for people. I think, the issue is like, well, yes, they're good for a lot of people. Are we paying more than we should for them? And that, that is a question of, that we're, things that you're looking at, like, the rate of the, prices increases over time compared to inflation. And particularly, while I don't know where it fits in the board's authority, whether it's sort of good value for money at the price, at the current price. And, there's lots of research out there that kind of looks at that value for money question. But in terms of the drivers, like, it's probably worth at least pointing out that one of the drivers is, that some of these drugs are really good drugs.
That's true.
Thank you. Kimberly Robinson.
Good afternoon. Just a couple of comments. I would caution the group to be thoughtful about some of the rhetoric that comes up in this space, I think on all sides. I would dispute the statement that PBM's motives is purely profit. I think there's a lot that goes into what PBMs provide in terms of this space. I would also proffer that no one who is choosing to make use of a PBM is doing so because they're paying more than if they had just paid for the drugs without that middleman intermediary negotiating on their behalf. And so, one could also argue that the cost of the drug always starts with the people who set the price of the drug, which is the manufacturer. And so I think that's why the work that this PDAB and others across the country are doing are looking really closely at where the cost starts, which is with the people who actually sell the drugs, and that then trickles down to all the people who are now acquiring the drugs for the people who need them. And so, I think the work that this body has been doing to really understand all the different sides of this, all the things that go into it, all the different entities who all have various motives, profit and otherwise, are all a part of that. And that I think we want to, be thoughtful about how we talk about all of the different players in here. I think everybody's got, with everybody, I think there's some good and some potentially bad about what anybody is trying to do in this space. But at the end of the day, the goal is to make sure that drugs remain available and affordable to the people who need them. And for those of us who are wearing different hats and are all part of this system are doing some part to try to make sure those drugs are getting to those folks.
Thank you.
I would just echo, it's a very good comment, and hopefully the structure of the stakeholder council allows the folks with all the different hats to be in the room. So appreciate that comment. That was very helpful. All right, we'll go to our last two circumstances, which have a similar flavor. I think Dr. Tunis kind of alluded to it, but we'll see where this goes. And then I think at the end, we can just stop, end with any kind of policy options that the stakeholder council wants to flag. So let's just go through these last two circumstances, then we'll kind of finish the conversation with any potential policies that can resolve the drivers that we've identified. So the last circumstance is that the total gross spend for Farxiga for state and local governments exceeds 1% of the gross prescription drug spend for the state and local governments. And then for Farxiga, very similarly, the total gross spend for Jardiance for the state and local government exceeds 1.8% of the gross prescription drug spend for the state and local government. So I think Dr. Tunis kind of alluded to this, but do you have any, Christine, you can go to the next slide. Do we have any ideas on what drivers cause these drugs to make up such a large percentage of the overall gross spend in the state? Dr. Tunis basically said that these are very good drugs, so there's a lot of patients on these drugs, which drives up the cost, which I think is actually a very good driver. I'm glad you flagged that, because just putting it in those terms was very clarifying, so thank you. Any other drivers that we wanted to talk through? Yes, Mr. Gamble. Oh, so you're on mute, or Dr. Gamble. Still on mute, Dr. Gamble. We might be able to unmute him. Oops.
Dr. Gamble, you're on mute. I'm trying to unmute you.
I think we can just.
Sorry about that.
No problem.
I'm a non-tech guy. I would question whether the use of these drugs would drive up the price of the drug. It should drive it down. If you're selling more of a unit, you can make less per unit and make the same amount of profit. I just question that. It's just general comment about capitalism. And I think that I don't doubt that they're very good drugs. The question that I have is where, and I've expressed, and maybe too severely, that I think that the loser in this process are the patients. The patients are digging into their pockets for the best drugs that exist, and the people who are leveraging them, or the groups of not necessarily individuals, but the corporations that are leveraging them, in my opinion, and I don't know everything about the pharmaceutical industry, are the purveyors of the pharmaceuticals and the PBMs. And I've heard a lot about profit, but I don't want to argue with the lady before. I'm sure that they convey some utility to the system. But the motivation for profit is great, both at the PBM level and at the pharmaceutical level with the purveyor. You talk about cost drivers. That I think that capitalism is cost driver for both entities. Thank you. Sorry about that.
Thank you, Dr. Campbell. I think we have Dr. Golden up next.
Yeah, I just wanted to comment about these medications. Now I'm wearing my endocrinologist, diabetologist hat. And do want to point out that the clinical practice guidelines from the American Diabetes Association, now recommends these agents for patients who have diabetes with, coexisting chronic kidney disease, heart failure, cardiovascular disease, which ends up being the majority of patients who have type 2 diabetes. So, just want to point out that the clinical practice guidelines actually support the use of the medications based on evidence-based clinical trials that have been published. And there's also a high prevalence of diabetes in the state, particularly certain parts of our state. So, I think that whatever we do, we need to ensure that access remains for these medications. But part of the reason there is a cost driver is because there's a lot of people with diabetes, and the clinical practice guidelines have changed in the last several years. And I will say it used to be, when I was practicing, that even if there was, and this still happens to some extent with payers, even if there's evidence that shows that this is the first line therapy for this particular group of patients with these comorbidities, an insurance company will say, well, we would like to show that they fail these other less expensive versions before we move to the next one. And then that is really not patient-centered care, and it predisposes patients to complications. So I think that is still a challenge, in many arenas. And that may be why, despite the fact that these are good drugs that should be being used more frequently, sometimes patients who need them still aren't getting access to them because of the cost issue. So just wanted to speak to that from a clinical perspective as, someone who's thought about the guidelines and the prescribing, and sometimes, the insurer is the barrier to you actually prescribing what the evidence-based therapy is because of cost.
Thank
I
you,
would
Dr.
just-
Golden.
I would also just, and it's also kind of echoes Kim Robinson's point, is that, I think everyone here is interested in increasing access while, again, addressing any affordability challenges. And to Dr. Golden's point, that was a point of discussion in the board meeting. They did find that certain populations may be underusing these drugs. So I think, again, the general finding is that these are very good drugs, and they did see differences in utilization in different patient populations, which they found to be a striking finding. So I think that's something we're continuing to think through, just in terms of increasing access, though it didn't make it into the circumstances.
Darren?
Thanks. I would agree with Dr. Golden. I'd also agree with Sean. These are good drugs. As for a driver, and I don't know if this is a driver or was, but because I don't know what the state plan is with respect to the products. But did the state or any of the local governments have an education campaign around whether the drugs or the diseases that these drugs are dealing with in the chronic condition space? And if so, maybe those education campaigns were successful because more individuals who needed them that may not have been on them then utilized them. So, that's a good thing. We have people that are getting medications to address chronic issues that might then decrease cost on the other side of the ledger later on. So again, I don't know whether using a 1% or a 1.8% increase sort of metric is useful here. If the medications were useful in lowering some other costs within the system. And again, I don't know whether what the driver could have been, but was that maybe an education campaign? Was that something else with respect to the benefit design?
This is Andy. That's a great suggestion. If anyone has any evidence, like that would be a driver. And if anyone has any supporting documentation that can help us identify that, would be helpful. Right. Dr. Gamble, sorry.
Clarify that I wasn't talking about the overall cost to the state, because true what has been said before, if you're using more more patients are utilizing the drug, you're going to have greater cost to the state. What I was talking about is cost per unit to the individual patient. That should drive that cost down. And it's more concern about costs for individual patient that should be the concern as opposed to cost to the state, I think.
Understood. Great. Thank you. All right. So I guess with the final question, we heard some policy recommendations, but I think we did. I think the goal was to kind of identify a driver and then go through the policies related to that. And that I'm not sure if I managed that structure very well. So I did want to just as the last thing, just see if folks have policy recommendations on making these prescription drugs more affordable. I know Mrs. Schultz and Mr. Johnson kind of referred to policies already articulated in comment letters. So I think those are all certainly on the table. You're welcome to bring them up again, though all those are being carefully considered. We had a lot of discussion around good policy solutions. But if anyone wants to bring up anything else that they feel like was not discussed so far, please feel free to do so.
Darren?
Yeah, thank you. I'll go to your, what is it? The benefit smoothing, Part D benefit plan smoothing. I won't get into the real specifics because there are lots there, but in general, this is something that pharma absolutely supports. And so if there is something that can be done around this, that would be, again, I think a non-UPL policy that would be supportive from the industry's perspective. And then, as you said, Andy, you have a lot of our other comments as well. So all of those, I think, would go a long way in addressing the issue that is before us.
Great. And just as a follow-up to that, not necessarily for Mr. Johnson, but I'd say the public as a whole. So this might be something that can come up in the September 3rd meeting, information gathering. Has anyone had experience with this in the wild yet? We know that it's a policy that Medicare has articulated, but we kind of at the staff level, want to find additional, folks with experience, different, like basically want to hear how this is actually working. I think it makes sense as a concept, but operationally can be very complicated. So any kind of real world experience that's out there, we would welcome that. All right. Any other comments on policy options?
Sean?
Yeah, I mean, just to say one thing that continues to be attractive about the upper payment limits, as where the focus of attention has been for the last few years, is I think the intent of that is right. It sort of is intended to put some downward pressure on all of the all of the elements of the supply chain, not just the manufacturer, but the PBMs and, all of the other, quote unquote, middlemen in the supply chain. So, I think, as you're pointing out, Andy, the fact that there isn't, a lot of experience in the wild about how things actually play out, much like most favored nation drug pricing policy, it's kind of like, yeah, there's, we don't know what all the consequences are going to be, but just conceptually, it is attractive to kind of keep the primary focus on the upper payment limit, just because it should logically, put downward pressure on, all the elements of the supply chain, and hopefully, also, create an environment in which companies that are not subject to the upper payment limit might would have need to factor the potential for the upper payment limit to be applied into, well, not just companies, but everybody, again, the whole supply chain, into kind of how their price increases over time are applied. So that's, I think I'm very supportive of, and I'm glad to see that you're exploring all the other potential policy options, including upper payment limits. But, just wanted to kind of reinforce why upper payment limits, at least conceptually, seem like, a good place to be focusing a lot of our attention.
Great, thank you. Great. Christine, if you want to go to that last slide, I think that's kind of what we've been discussing. Yep, there we go. Yeah. Any other comments or questions on policy options that the Stakeholder Council wanted to provide input on for the board to consider? All right, Chair Diana, I think looks like the discussion has run its course. Actually, I might just end with one point here, and it could also happen during the administrative update, but just wanted to thank the Stakeholder Council for all the great input. I know we gave a lot of information to you, and you've been, responsive on a very quick turnaround. And then also, this is the first time that we've done that. So I think gone through this process. So we welcome or very much appreciate that you guys have helped us navigate this process for the first time. And I think we have some good lessons learned for the next rounds of information gathering. So thank you for the great participation in this and the great suggestions.
And I'd also like to thank everyone for a robust discussion today. This information in this discussion will be reported to the board. Christina is now going to give us an administrative update. Christina?
Thank you, Lorraine. So we have 3 new PDASC members that have been appointed, and I was hoping that they could maybe give us a quick introduction today and tell us what brought them to or their interest in the PDASC. Dr. John Gambrell, would you like to give us a quick introduction of yourself?
I'm an old man. I board certified ophthalmologist, 47 years of group practice, recently retired, navigating the insurance system on my own for all my illnesses and buying my own pharmaceuticals out of pocket. So I have the same concerns that any individual has in the state of Maryland, and I was offered this position, and hopefully I can do some good for the patient population in the state.
Thank you. We do look forward to working with you. And I forgot to mention this. He is one of our newest public members, and he was appointed by Speaker Jones. So thank you for joining us. Up next, I have Erica Miller. Erica Miller is also one of our new public members, and she was appointed by the governor. Erica, would you like to give a quick introduction?
Sure. Good afternoon, everyone. I'm Erica Miller, a Baltimore City resident residing in the 21217 zip code. And yes, this is my first meeting as a council member. I serve as the Senior Director of Data for a geospatial tech company, and I'm also the founder of mpdtm.org, which is the nonprofit data and technology management organization. And I can just say, based off of the robust discussion today, my passion is I'm a data sourcer, integrator, aggregator, and storyteller. And I joined, I wanted to be a part of the board as the Stakeholder Council is because I experienced firsthand the varying cost with prescription drugs. I have to make decisions, or I had to make decisions between paying for prescription drugs or taking care of my family. And my prescriptions are what helped me to take care of my family. And so when the opportunity presented itself, I felt that it was only fair for me to do my part as a Marylander and stand and be a voice. And so I know that a lot of discussion was made today, and we can discuss and debate policy all day. But as someone on the other side of this that is a patient consumer, we have to move swiftly, we have to move fast, and we've been entrusted with a lot of responsibility. And I'm looking forward to contributing my part and helping to expedite that. So thank you. I look forward to meeting you all.
Thank you. We look forward to working with you. And then lastly, I have Robert Embry. He is our new representative of employers, and he was also appointed by the governor. Mr. Embry, would you like to say a few words about yourself?
Subject I'm very familiar with. I'm a native of Baltimore. I'm a member of the bar, practiced corporate and tax law for a while, elected to the city council, was housing commissioner and assistant secretary of housing, and worked co-partner in a real estate development company that developed properties in cities around the country. I've been a foundation head for 38 years and board of the Greater Baltimore Committee, which represents the business community in Baltimore.
Great, thank you. We look forward to working with everyone, all three of our newest members. So I do have a short list of updates that I'm just going to go through very quickly, if that's okay. So fee assessment for fiscal year 26, those invoices are going to be mailed at the end of this week. Those payments will be due October 1st. So I just wanted to let everyone know that. The September board meeting was moved from September 15th to September 29th. This will now be a virtual meeting, and more information will be posted on our website in the coming weeks. Dossiers for Ozempic and Trulicity were posted on August 20th, 2025. Comments are being accepted through September 4th, 2025. Please visit the website for more information on how to submit comments and the information that we are seeking. And as Andy mentioned, the informational gathering hearings under COMAR 1401-05-04D1. The board through staff is convening 2 informational hearings to receive input, information, and opinions from the public and stakeholders to assist the board in developing policy to address the affordability challenges created by the use of Farxiga and Jardiance. Those hearings will take place on September 3rd at 1:00 p.m. as well as 6:00 p.m. All of the information to register to speak at those hearings or to register just to listen to those hearings are posted on our website. So please consider attending if that's something that you're interested in. Mr. Johnson, I just have one more thing. Lastly, staff is exploring the possibility of having an in-person hybrid PDASC meeting based on feedback from a member. So we're looking into that, and more information to come. Lorraine, we have a member that has their hand raised.
Yes, Darren.
Thank you. So for the informational hearings in September, are there 2 there's 2 on September 3rd, is that right? One at 1
Yeah, so we're
o'clock and one
doing
at
a
6 o'clock?
daytime here. Yes, there's a daytime hearing at 1:00, and then there's a 6 p.m. hearing to facilitate participants outside of work hours.
Okay. Can you all tell me or tell everybody listening, what is the intention of the staff, the board, with respect to allowing for substantial comment time? Again, I mean, I'm not going to go fully into everything, but you know my position on the 90 seconds that we have here at the Stakeholder Council. I would strongly encourage, recommend that the advocates, be given 5 to 10 minutes to really articulate what they need to. And I would also hope that there's questions that are asked of the advocates, so that the board can get and the staff can get more information around some of the issues that the staff is looking for. So I just wanted to see if you can say anything about what your timing is going to be with respect to the number of folks testifying.
Christina,
Andy,
you
would
want
you
me
like
to take that? Yeah.
Yes, please.
Yeah, thanks, Mr. Johnson. We appreciate the comment. So I would say that these informational hearings are almost, I don't want to say direct response, but this is supposed to be the forum where folks can provide more in-depth input and feedback. So there's no specified time limit for testimony. I mean, there may be some element of time management. So I think the chair will have the ability to help manage time, but I think the intention is for any speakers to get as much time as they need to communicate their point.
Thank you. I totally agree, and I appreciate, and I understand the time management issue as well. But what your answer is very adequate for me. Thank you.
Dr. York, it's your lawyer. I just wanted to clarify for Mr. Johnson. It may well be, depending on the number of individuals who are registered, that there will be a time limit that is set. we would not anticipate that it would be 90 seconds, but again, in the interest of time management.
Understood. Totally understand that. Thank you.
And I believe that information was mapped out on the PDF that we provided on our website regarding the informational hearings as well. So I hope that's helpful.
If there are no other questions or comments, I want to thank you all for your time today. And the next PDASC meeting will be on October 27th, 2025. Mark your calendars. And do I have a motion to adjourn?
Motion to adjourn.
Thank you. And a second?
Second.
Thank you. And the meeting is adjourned at 3:46 p.m. Thank you again.